then we had molecular classification based on a study which was published in 2010. With differential gene expression, medulloblastoma can be divided into 4 subtypes. Now we know medulloblastoma is not one disease. Okay? It's 4 different subtypes. And what's important is that they have different prognosis. If you look at this, this is group C disease. It has the poorest prognosis of all medulloblastomas. This data also gives us information about the age of the child, the type of mutations that different subsets have, and so on. Very important in tailoring therapies. For example, we know the Wnt pathway of medulloblastomas, which constitute about 10% of all medullos, have an excellent outcome. So you can try to reduce the therapy, especially radiation and or chemotherapy in these patients, and still get a good outcome, and thereby reduce long-term toxicities. Personalized care. With this knowledge, we have entered into a collaboration with St. Jude. In fact, we've been in collaboration with St. Jude since 1996. This is a new trial that's come up with specific treatments for the specific subsets of medulloblastoma. For example, what's known as sonic hedgehog pathway, which affects about 30 to 40% of medulloblastoma patients, we incorporate targeted agents like GDC-0449 against sonic hedgehog pathway, in addition to radiation therapy and chemotherapy. This is based on a study which was published in New England Journal of Medicine a few years ago, which showed that if you do GDC-0449 against smoothened in sonic hedgehog pathway, you get a very good response, although it wasn't long-lasting. But still, it gives you hope that in combination with other drugs, you could do this. But again, there's more nuance to this. GDC-0449 doesn't work in all patients with sonic hedgehog pathway disease. There are other mutations within the pathway against which this particular drug is ineffective. Based on genome sequencing, we have seen recurrent mutations in medulloblastoma, MLL2 and 3, ATRX mutations, histone gene mutations in high-grade glioma and DIPG. This is extraordinary. We have never had this information before. ACVR1 mutations in DIPG, BRAF mutations and fusions in pilocytic astrocytomas, and RELA fusions in supratentorial ependymomas. I'm going to focus a little bit on BRAF mutations and fusions in pilocytic astrocytomas. The exciting thing about this is the type of mutations or fusions that we dream about, because this constitutes a single pathway disease. In pilocytic astrocytoma, it is a MAP kinase pathway disease. There are multiple mutations within the pathway that could cause pilocytic astrocytomas, but they are confined to that single pathway. So if you develop drugs for that particular pathway, like MEK1 and MEK2 inhibitors, you can hold this disease at bay, especially in the young child with centrally located pilocytic astrocytoma, where you don't want to use radiation therapy up front. So this shows you that majority of patients have the fusion transcript, and few of them have V600E mutation, and so on.